Well, it's really exciting to be here. Brian and I have been friends for 25 years. Our kids know each other really well. We vacation together, so it's really exciting. And also, Ron's, a lot of people at Northwestern do a lot of this work. So it's exciting. And so just to get started, so I work on the adherence problem, right? There's this drug out there, which is unbelievably effective, but people won't take it, exercise. And so I really just obsess about how do we improve the adherence? How do we get the people who need it most to actually use it? And so my only thinking these days is that there's only two ways to accomplish that objective, given the research, and that is make it fun or short. Maybe I'll come up with a third way, but that's our general approach at this point. I don't want to, and I focus on older adults at this point, partly because that's where the money is. That's where you could save the most money by making this thing happen. And then the numbers aren't great in general. There's no more than 20% of older adults will meet national guidelines for doing strength training a couple of days a week. It's even lower than that if you take into account the aerobic exercise recommendations. So, I usually throw the number, I say no more than 20%, is probably closer to 10, about who actually are adherent to this amazing treatment. We've really recently finished a 5-year, 1,100-person study of an exercise program to reduce falls. I show this only just to give a sense of, even when you enroll people in a trial where they have to sign a bunch of documents, they have to come and do baseline visits, they're really motivated. The first, you might get them to do 8 sessions a month early on, and over time, that will reduce down to, this is a little over greater than once per week, or 5 times per month on average, among a very highly motivated group of people, where you made everything as easy as you could. You had coaching phone calls, a lot of effort. It was a standard of care intervention, 45 minutes, 3 days a week, strength, balance, and some aerobic work. So this is really the standard of what you're seeing when people maybe join the Silver Sneakers program. All of the non-adherence happens relatively early. Sorry, these are calendar months, not participant months, but in general, you see it start out and go down to about maybe 60% of where it started, and then stay there. So it's a very hard behavior to change. And when you ask people why they don't do it, this is what they say. They use the time word a lot. I don't have time. And so, it's interesting. These are the other words they use. It seems like work, I'm lazy, I'm not motivated. This is a word cloud we made from some qualitative work that we do. But I do think that the word time means something strange and different to different people. So, obviously people over 65 on average don't work as much and have time. Everyone has the time to do it, but it's really about prioritizing it. And so we've been thinking more about, so I'm a primary care provider also. And so I'm thinking more about exercise. If it's medicine, maybe we should think of it in terms of the drugs we use when we treat hypertension, diabetes, and other things. Is we don't go for the maximum dose. We go for, what's the smallest dose that will get us where we need to be? What's the lowest effective dose? And so I'm going to go through some of the work on, briefer workouts. High intensity interval training would be what a lot of the public knows it as. And so I'm really going to cherry pick some of those studies to look at what is called low volume or brief high intensity. And so this is a systematic review, and oops, I think I'm still learning the cursor. It's very high tech. On average, this was really only asking 11.5 minutes per week of people. For those who don't know the guidelines, it's typically 150 minutes per week of aerobic activity, twice a week, full body strength workouts. Typically, you're going to get to at least 45 minutes or an hour for the week. So this is 11 minutes a week, which led to some really impressive VO2 max changes. I think by now everyone sort of believes that HIIT works, and it can be brief if you want it to be, but it's probably going to have to be hard to get there. And there's also some data showing from population studies that that brief, intense activity leads to reduction, or is associated with reductions in mortality in cohort studies. So this is a UK Biobank study. There's been several studies published from it, and so what's interesting about that, this is duration minutes per day. So this is like intense, vigorous activity that people did as part of their life, their normal life. Even a few minutes per day had pretty nice reductions in cardiovascular outcomes. This has been published in a cancer population as well, using the UK Biobank data. But more and more the evidence shows that 150 minutes, that's probably going to need to change. If you can get people to work hard, you're definitely going to need less than that. One of my favorite studies is from Martin Gabala's group at McMaster, where they did a randomized trial comparing 1 minute a week of exercise versus 135 minutes per week, randomized trial. So the 1 minute group came in and they did, sorry, it was 3 minutes a week, I lied. 3 minutes a week. So they brought them in for 3 20-second sprints on a bicycle. Rest for a few minutes, repeat. It took a few minutes to do it. So 1 minute total of exercise. I'll see you on Wednesday. I'll see you on Friday. 3 days a week, 3 minutes versus 135. And they're in this study, they're including the break time for the time commitment. But in general, so they call it the middle column here. This is sprint interval training, because these 20 seconds weren't very enjoyable, let's just say, really, really hard. So sprint interval training, but they saw the same improvements in VO2 max and fitness if they did it for 135 minutes at a lower intensity, not 0, or they did 3 minutes per week. And so this is just more evidence to say that 150 minutes is sort of older recommendations. We have to think about if it's hard, it doesn't need to be long. And so in both of these conditions, you saw 19% improvements in VO2 max, whether it was a 70% of the heart rate or over 90% max predicted heart rate. So I think thinking like a doctor, it's like, what's the lowest effective dose to improve strength? So pivot a little bit from aerobic into strength. So there have been a number of studies to look at, and the simplest way to look at this for strength is that when people go and do a strength workout, they have this tendency to do 3 sets of this, 3 sets of that, 3 sets of this. So most of the studies looking at briefer versus longer are multi-set. So I'm going to do 3 sets of these 5 exercises, or I'm just going to do 1. And so there's systematic reviews now looking at multiple set workouts versus single set workouts, which sounds academic and boring, but if it's not fun, I mean, I think most people would prefer something that's not fun to be shorter. If it's fun, let's keep going. But if it's short, let's get it over with. And so this is comparing 3 sets of an activity versus 1. And in general, for most of these, so this is single set SS. Again, it's a small trial, but there are many, many like them. Single set versus multiple set, you're seeing fairly comparable changes in either upper limb strength or lower limb strength. There's a small, there's this one here, single set 1 here, but there's not a significant difference. Again, it's small, so you might not see statistical differences, but that is the standard for a bunch of these multi-set activity studies versus single set. This one was done among people. So the previous study was older adults older women who were not gym rats. This is younger people who had done some strength training before. So different populations. I get it that, you know, it may not always be the same, but this one compared randomized trial, 1 set per exercise versus 3 versus 5. So, you know, huge differences in total time commitment, but really not any different in terms of the outcome. They improved their strength, and even the group that only had to do 1 set actually improved their strength, 1 rep maximum, the most. So these studies, when you add them all together, basically say that I think this is sort of what I tell people. I think this is the best summary of it. There's a systematic review of looking at how much you do strength training, how many sets do you need to do. Basically, most of the improvement in strength will come from the first 0 to 5, actually, 0 to 5 sets per week. So if you do it 3 days a week, that's once or twice at most. Most all of it's the 80-20 kind of rule and principle in action. And then if you want to, if you're like an elite athlete and you really want to get all the benefit, you could keep doing more. But if your goal is to get strong and not have it be soul sucking, I'll use that term again, you can get it done very quickly. And so the first 5 sets will get you, you know, 80% of the possible strength gain you can have in a week. Which I think is sort of uplifting and optimistic for those who don't find it to be the most enjoyable way to spend an extra hour of your week. And there's many studies to look at this. So I'm always looking, I feel like my PubMed queries are set up out of some deep sense of laziness, because I have all these PubMed queries about like brief and, you know, what's the minimum, you know, feels a little lazy. But there's systematic reviews on, you know, what's the minimum? You know, again, thinking like a clinician, what's the smallest dose we can use to get this outcome that we want, I think is a neat way to look through it. And so in general, I think the quote that comes from this, which is nice, I don't want to belabor going through all the data, but, you know, a single set performed 1 time, a minimum, and 3 times per week led to some, this is changes in 1 rep maximum. These are in kilograms. So, you know, it's just a 12-kilo increase in chest press is not a small amount, you know. So you can get a lot out of doing very, very little. The key, of course, is it has to be kind of difficult. You have to try. It has to be hard. And so one of the studies I think, and this is how I organize my own workout, is that in general, I always tell my patients, you know, if it's not fun for you, do 1 upper body push, 1 upper body pull, and 1 lower body push. Each of those movements works 5 to 7 different muscle groups. They're very functional, and that's all you need to do. And so at a minimum, you need a leg press, an upper body pull, an upper body push. So there are, for those of us looking for the easier way, there's a lot of people kind of looking at this approach. And so I'm going to pivot a little bit to some of the older adult programs. There's a lot of studies on the kind of standard 45-minute approach, 45 minutes, 3 days a week, which is still sort of a standard. If you go to an in-person Silver Sneakers session, that is generally what you're going to see. It's 45 minutes. It's offered 3 days a week. There's some balance. There's some strength, a little bit of aerobic in it. We're going to call that the standard of care. And so I'm really been focused on, you know, people looking for shorter ways. So this is a study where in a facility, there are healthcare aides, nurses assistants. There are people there who get to know the clients, the residents, depending on how long they're going to be there. So in this case, they asked the residents to do 1 set of sit to stand. So this is just sit, stand, sit, stand, sit, stand. You can think of it as a squat. So like one of like the most fundamental lower body pushing exercises is a squat, but standing up from a chair is the same thing. And so they had them do it 4 times a day, and they had them do 1 set for 6 months. which is it's brief, but it's nice because they could be there to make sure somebody didn't get hurt. They could be there to encourage them. They just need somebody there to tell them to do it. And these were significantly older adults. So 80 these are mid to late 80s. And this is not a randomized trial. So you'll see that the baseline means are not the same. But the difference is over 6 months, the intervention group got faster in standing up once. The control group got significantly slower in how many seconds it took them to stand up once. So in both of these, this is about a second faster, a second slower. It's not the best designed study, but it certainly gives you a sense that maybe there's some effect there, that just doing this really simple exercise that didn't need training, doesn't need equipment, and the healthcare aid could make happen, might really improve some predictors, some important body parameters of independence. And so the sit to stand exercise is a real fan favorite for people who study older adults because it's so easy. It doesn't require, you have to do it every day anyway. So it's like the ultimate functional activity. Getting up from a chair and repeating it over and over is not easy if you haven't done it very often. So for the most part, anybody who tries to do it and does 30 of them in a row quickly will breathe hard. It's a very large group of muscles that do it. So the heart rate will go up. If somebody doesn't have a nice increase in heart rate after doing 30 of them, I'd be very surprised. It's very hard work. So this is a study out of Japan where they had them do it repeatedly. They had them do 48 of them once every 3 seconds, 3 times a week for 12 weeks, which is a lot and very hard. And with the populations we work with, I'm not sure they could finish number 48 or frankly number 28. But it was a very simple workout. And they had some really nice improvements. Again, these are, when you do these studies a lot, they're not clinical outcomes necessarily. Knee extension, torque, the ability to move. And so saw some really nice improvements. And at least this made people seem stronger. They were able to extend their legs with more torque between baseline and follow-up. It's not a standard deviation, but it's a decent effect size of 0.6. So a decent amount, even doing this one very brief, simple exercise. So we've taken a lot of that into, I'll get to our work. So we've taken that into what we call FAST, or the Functional Activity Strength Training Program. We're trying to, again, find out the minimum. What's the minimum we can get people to do? We've done a lot of qualitative work with people, and what we've kind of taken away is this general belief that if Silver Sneakers is 45 minutes, 3 days a week, and I know now they partner with Apple Fitness, and you can find briefer video workouts. I get that. But if you're 75 and you haven't worked out for a while, and your insurer says, hey, we've got this amazing thing, you should try it, right? Asking you to go do 45 minutes of that, if you haven't done it in 30, 40 years, is like asking me to climb a mountain. I am not sure I want to walk into that room because I'm going to be, first off, I'm not sure I could finish. And if you do not think you can finish, you're going to have to walk out with your tail between your legs. And frankly, you might hurt yourself. You're not going. And so we'll share some data that kind of suggests that that's really the case. So we've really just been focused on and so in our trial for 5 years of that 45 minutes, we realized that we maybe needed a different approach. So these are very basic exercises. Again, it's upper body push-ups, lower body push, chair stands, upper body pull, rowing, and then we add a stepping exercise. Our population of interest is people who can't walk well. In BRFSS, a Burfess risk factor surveillance system, there's a question, do you have serious difficulty walking or climbing stairs? And a quarter of older adults say yes. And that feels like a very high number. Not that I think it's inaccurate, but I think it means it's a common problem, serious difficulty walking or climbing stairs. We know, a third of older adults will fall in any given year. So mobility problems are really, really common. So this is really our clinical population. So that we really designed this specifically for people who say they have difficulty walking. So we have 2 lower body exercises. One is stepping. We added actually a 5th one to the trial we have, but I'm just describing a randomized trial, a pilot randomized trial we did. And we had multiple ways that people could do push-ups. They're very hard. You can do wall push-ups, which I call placebo push-ups. But then you can move to doing them on a kitchen counter, which is amazing. 36 inches is like perfect height. If you have steps, then you can go to the 5th step. You put your hands on the 4th step, 3rd. So we had ways that we can work with people for how to do it so that it's useful, but not overwhelming. So there's a lot of modification. Chair stands are great. Rowing, we just send them a set of bands, which is really nice. All these things are inexpensive. I mean, it's not a zero cost option. Steppers cost $20. I'm on Amazon. And so the way we started this, we actually started it during COVID, and we had just 24 older adults. And we also wanted people to do it every day. We wanted it to be a daily routine. Habits are best when they're daily. You set up your cues better, your routine. So we had 24 people do 30 seconds of push-ups and squats. We did this all by a timer. We just try to make it into if you want to keep it brief, we just figured that we would have a timer. So we had 30 seconds of push-ups and squats with a 30-second rest period. We recorded a countdown timer. I recorded it. So they had to listen to my soothing exercise voice, but they would push the button. And then every day there was a red cap survey that would go out every day. It would give them the timer, video if they wanted to remember how to do the exercises, and then a link to report what they did. So if we got an answer back from them, we assumed they did it. I mean, you could lie, but that's a lot of work to go through, responding every single day that I did it. And so what we learned in this is, this was during COVID. We couldn't test people in person, but it was fun. It gave us something to do while we couldn't do a whole lot else. Because we fortunately sent these letters out in like January of 2020, so we got lucky there. But we got about 24 older people to try this. Again, I actually sent these out to all my patients. So I did this as a QI exemption to the IRB, and I asked them all just to do it, period. And so we got a bunch of people to try and report each day. The number of chair stands they can do went up nicely. But again, it wasn't a randomized design. But we got some pretty impressive, I think it was like 75%, sorry, like 70% of days people did this, which I thought was pretty good. It was 6 months long. And so we were kind of encouraged that, people's push-up and squat performance, again, self-reported, not, valid and reliable. But it did give us a sense like, maybe this is the format that works for people, something daily, something brief. They seemed really shockingly willing to do it. I sent out like 140 emails and like 40% responded and did it. This is just 20%. This is just the people over 65. So we had a lot of interest in it, and it seemed like, okay, maybe this is a format that works. So I did the audio timer. The messaging has always been set a PR, set a PR, set a PR, set a personal record. So it's only 30 seconds, but each week we try to get people to do one more than they could do the week before. When you start setting PRs, you're improving. So if you do a baseline and follow-up measure, you're definitely going to see improvement in that. And what we found is that people really seem to like self-improvement. They liked doing something that they knew they could not have done in the past. I kind of think most humans are inspired by that. Not beating, some people love to just beat someone else. But I think everyone has this joy when they think, I couldn't do that before, no matter how hard I could have tried, and now I can. So that's like our only motivator for some of this work. Honestly, that is really keeping it brief, have people set PRs, and then have them feel good about doing something they could never do before. Great. And so in the meantime, we've done some survey work. We have this written up right now. So we did a survey 2022 using Qualtrics. And this, I'm just going to focus on this one question. And we were trying to see, would people be interested in this? We were really worried that if we offer something brief, people would be like, that's not going to help me. I'm not going to try that. You know, that's a placebo workout. Rather than we thought they would see it as something they could do and be enthusiastic about trying. But if you don't believe it could work, you won't try it either. You know, it's like, why would you do it? Why would you do it if you think it wouldn't work? So we asked this one question. We asked others, but I'm going to focus on this. Assuming that all programs include similar exercises, and we also had, we didn't. We just similar types of exercises. Which would you prefer? So we didn't even say it's proven to work. We just said, assuming that they had similar exercises, what would you prefer? 45 minutes 3 times weekly. Again, to me, that's the standard of care silver sneakers approach for 5 minutes each day. We had some qualitative data. We surveyed some people, did some qualitative work prior to that about what people think. And we definitely came away from this 45 minutes is really too tiring for people who are 74, average age of 74. They're not sure they could even do it. They don't think they have the strength. And obviously, like all humans, they would think 5 minutes would be easier to do. It would be more appealing. I could always make time for it. I don't like it. The quicker, the better. I think that's sort of a nice way to approach how a lot of people feel about exercise. I think I can make it a habit. And honestly, it's really hard to make an excuse to not do 5 minutes. I think that's the nice part. You can come up with an excuse for 45 minutes, but a 5-minute workout in your house, you really have to do some mental gymnastics to come up with an excuse for not doing that unless it's an injury, So this is a lot of data, but so these are the groups. So 68% preferred, again, this is preference. I get it. We didn't offer it to people. This is just getting preferences, trying to understand if our hunch was right. But 68% thought if given the choice, they would prefer a short one versus 31%. So 2.5 times or so more. But what's interesting is who was in each bucket. The only real difference, there was slightly more women preferred the shorter workout. Not any huge difference in terms of age. People who were heavier, the average BMI was higher for the 5-minute group. So not surprising, that would probably be easier for them to do. No differences in past history, past medical history, no matter what chronic conditions you had. The interest was still, again, about 68 to 31. But what really stuck out was the fact that people who preferred the 5-minute workout were doing, on average, much less of everything right now. So days of walking, this group, it was 3.8, this group 4.6. Days of getting some moderate exercise, 2.4 versus 3.8. In every parameter, it looked like the longer workout was essentially selecting for people who were doing a lot more. Obviously, they had to feel they could do it, but it's odd. And there's a selection. There's a publication where somebody looks at this and kind of wonders if it's an insurance selection factor. I'm going to offer this great workout, and so the people who are going to sign up for that are healthier, and they're the ones I want to insure. Now it's standard, so that I don't think you can make that argument. Now all of them offer this, but it does seem like it is selecting. These longer programs are selecting for people who already do a lot more. And the real thing that struck us is that in terms of people who have serious difficulty walking, it was 5.5 times more interest in the short workout versus the long workout. The same pattern appeared in people who fell. So people who have mobility problems just vastly were more interested in something briefer. And this was driven partly by, we have the self-efficacy measure, the 5-item self-efficacy measure. In short, people had much higher, 50% higher self-efficacy, so more than a standard deviation. You know, not surprising. If I ask you if you could work out for 5 minutes or 45, it would be impossible for people to think that they have more self-efficacy for the longer workout, because it's hard. So, you know, we think this is the big driver in it. People who are doing a lot today believe they can, and they're more likely to prefer something longer. And people who are more ill, have mobility problems, have health challenges, have poor self-rated health, feel like they could do something brief, much more than they feel like they can do something long. So this is the 45-minute workout. People who had walking difficulty, their self-efficacy there's 2, like 3.5, 3.3. So huge differences. So if you provide something brief, it does look like many, many more people who are ill think that they could do it. But in these studies, we realized there's a problem in how do you get people to work hard enough. That's a really big problem with this, is doing anything is not necessarily not necessarily enough. So we did then a randomized trial, 97 people, and all these were done on Zoom. So we had, it was again 4 minutes, 4 exercises, chair stands, push-ups, stepping up on a stepper, and doing 2 arm rows. 30 seconds each, 30 seconds on, 30 seconds off. So it was done in 4 minutes. And all the messaging is about setting a PR. We had really good adherence, 81% of days. They had to fill out a red cap survey and even tell us how much they did of each one. So it was kind of laborious, but they returned those on 81% of days, which was nice. And the 5 times sit to stand test went down really nicely, more in the intervention control. The number of chair stands they can do when it was made it, large differences. No shocker, we had them do them every single day. And exercise is specific. If you train on something, you're going to get better at it for the most part. But we didn't train on the one leg stance test. That improved. So, with 3 tests, we had to do a lot of these also COVID, so we could assess these things using Zoom. So we had test retest. We had blinded reviewers do test retest on them to make sure that we had the right assessment. This really seemed like that, and there was a delayed control. So this really seemed like this brief workout might improve some parameters that matter. But the problem was, for the first month, for the first couple of months, I did the QI. We had Zoom recordings, so I got to watch all of them. And what I saw kind of scared me, because early on it was really clear that people weren't working very hard at all. That I didn't see the levels of effort, and the RPEs were pretty low. This is the rating of perceived exertion, and this is what we ask people. How hard was that exercise on a 0 to 10 scale? This has been validated in a bunch of populations. The harder you report, really correlates nicely with heart rate and likelihood of improvement down the road. This is a really nice measure of, are these people working hard? But what we saw when this started, and this is calendar month because we changed it at a moment in time, what we saw was we were getting RPEs. When I was looking at the videos, I was like, there's no way people are working hard. There's no way people are working hard enough to get anything out of this. And sure enough, when we looked at the RPE data, we had RPEs of 3. So you can see that is somewhere just north of easy, not even somewhat hard, right? And so at that moment, we worked. We had some other co-investigators as well, some behavioral scientists, and we changed a lot of the messaging around. We changed the audio recording people have, and as well as the email people got each day, and we really focused people on personal records. Beat your PR every week. try to do one more. If you want to walk better, you're going to have to be able to go faster. And this is the way. And the only way to do more reps in 30 seconds is literally to go faster, right? So we just had this message of speed, beat your PR. It was during the Summer Olympics, so we could bring that into it. And, keep working hard and try to go faster, go faster, go faster. It was a fairly simple approach, but we got some really nice improvements in RPE, went from an average of 3.2 in the first few months to an average of almost 5. So people, that's somewhat hard, I think, if I go back. There you go. 5 is hard. So we got people to work hard, which I thought was nice. But it really gave us a sense like, oh, that's a behavioral trick we can use and keep using. Go faster, work harder, set a PR. And we had the coaches meet with them every other week on Zoom, and we would congratulate the people who did better because it was something that they couldn't do prior. And we knew the only way to get there was hard work, so we wouldn't pat them on the back. Now what we're doing, so we use that data to get funding for 700 person trial funded by PCORI to compare a standard of care. So at kind of 45 minutes, 3 days a week, you can see from the survey how we set that up versus our 5-minute a day program. We added a walking exercise, walking laps back and forth. So it is 5 minutes, 5 exercises. So it is a 12-month intervention. And we're really just starting that. I think we've enrolled 50 people now. And we recently were funded by NIA to do the short workout versus control. So we'll sort of in 2 studies that are going on at the same time, we'll really have a sense of, does it outperform standard of care, and what's the impact versus a control group. But there's also some real advantages of short. I'm just going to go quickly here, is that, the sense is probably there's a lot more people who would do it. So if only 20% are engaged today, if we could go to 40, I mean, that would obviously be huge. It's clear that from our survey work, there's a strong sense that more people would do that thing because they feel more confident they can do it. And particularly those who have trouble walking, people who are sick, who need it the most. We think more people can stick with it. Our data showed 80% daily session adherence. But, if you look at, no matter what studies you can look at in exercise, you'll find enough studies that even showed in-person adherence rates like that. So we'll see if that translates down the road to effectiveness studies. But you could argue that it's easier to do something brief that's in your house, that you can set a routine around, and that it is really short. You don't have to travel anywhere. We also think, you could do this in a hospital room. So we're working with one of the inpatient units to do a demonstration project that they're going to fund, that they're going to do the work. Because if our hospital, right now, about 40% of people older adults, go from being in the hospital to another hospital, right? Subacute nursing facility, or they get home care at home. Average cost of that's like $7,000. So they go from one expensive hospitalization to $7,000 worth of care over the next couple of weeks total. And we figure the goal is to find ways to save insurers money. I mean, let's go to the dark side. If we can save insurers money, they would use that thing that we're making, and we wouldn't have to convince them of anything, because it turns out everyone likes money. You never have to convince people that money thing would be worth it, as long as it's not too hard to get there. So we're going to do some work with inpatients. And the other nice thing is that if it's 5 minutes long and you Zoom coach people and you want to watch them do their whole workout, well, that's short too. And then FTE, most of the intervention expense is people expense. And when you reduce the people expense, it's like this virtuous cycle. So the Zoom coaching would be less expensive. And so I think now our overall strategy, just getting a dose of reality, is how can we save organizations money using brief workouts. And if we can do that, we're good. But if we can't, I'm not sure we can really scale something. The history of scaling interventions that don't save real money is poor. I mean, I think even the DPP is a really good example. There's data that shows for some reason they haven't palpably believed that if they put really serious effort, they could get everyone engaged in this. Our goal is to save them enough money that they don't stop trying, that they try to find all that money they can and get everyone involved, get the providers, if they're hospitals, to do that. So that's what we're trying to do. We'll see if it works. I'm hoping people have some questions. People have been quiet, and I'm sure, but I really appreciate the chance to talk to the group, and I'm really curious what people think. We're just trying it. So we don't know what's going to work, and we don't know, even if it does work, what would happen afterwards. Ron.
Chris, that was great. I have a question. Methods.
Yep.
So you showed really that activity for fitness or similar data for insulin sensitivity. What matters most is that they're doing sort of high effort for a short period of time, or moderate effort for a little bit longer period of time. And is that the most important thing to measure in a study of physical activity? I know that go through Herculean efforts to measure accelerometry, and there's self-report measures. And, given the data that you showed, people could, if you're doing a high intensity 20 seconds multiple times a day, you're not going to have changes in accelerometry depending on how it's configured. So I guess it's a question of how you get your grant reviewed and funded, what measures do you need, but also what is the most important thing to measure in a physical activity study?
Yeah, I think to get funded, you have to show that you can change a mediator of something that deeply matters, a clinical outcome, a mediator of a clinical outcome. And so we've done our pilot work trying to change a mediator of what we think is a clinical outcome. And then in the large scale trial, we power it based on things that are, we'll call them clinical outcomes, whether it's a fall or things that are much more clinically oriented, things that hospitals would have to pay for. We get more clinical as much as we can. Does that answer the question though? I'm not sure it does.
For those that are.
Yeah. Oh my, I mean, I think you have to have the most, the most valid and reliable measure of the mediator and outcome as you can. I mean, I think self-report for physical activity is just kind of dead. It's vastly over rate stuff. Strength training is hard. I don't think there's a kind of, there's a directly observed measure for that behavior that I'm aware of right now. Accelerometry is fantastic. Again, as a mediator, but then, if it's diabetes, you're going to want it to be A1C, something really clinical. So the reviewers go, wow, that's important. I think everyone believes clinical measures are important as long as you can kind of prove that, like the good example, in drugs, it's the same thing. You do a statin trial, you do the studies that show you change the cholesterol, and then you kind of scale up to change a clinical outcome. But you absolutely have to have, valid and reliable measures. And so no self-report, you don't have, I just don't think you can do it. RPE is pretty good. I mean, we're stuck. There's no other, I guess in theory, we could have done, heart rate changes as that mediator of RPE. We haven't gotten dinged on that. And partly because people are doing something right then, they have just no incentive to lie too. But you're right. I think, all your measures have to be good for sure. Other questions or anything online? We're going to end this with a brief workout. So no. Please. Oh. So it's actually to know PCORI is to love PCORI, but they have their own ways. So the main outcome, the main powered outcome is the PROMIS physical function measure. So it's sort of a self-reported measure of ability to do several things. Well, the secondary outcome is 6-minute walk test. So that's like, in terms of mobility and walking, the 6-minute walk test is like the most clinical one. They actually do it in some clinical settings. Pulmonologists do it. So it feels really clinical. But those two are kind of the two main, but the main powered is, it had PCORI kind of requested that. So we have enough people to do other measures. So it wasn't exactly, it was just giving the statisticians more work, which is fine.
So you're going to be learning much more about this. But even in the small sample studies, you have variability in it. What have you learned about
It's interesting. Honestly, we haven't dug all the way down into that. It's very strange. It's like when you have good news, how far do you dig through it to find the bad news? And you're right. No, I think, yeah, you're right. And so we're going to continue. So in this trial, we have, video monitoring, we record things. We are going to keep digging into, because I think I got a lot out of doing the video review and finding, that there was a problem, and I'm assuming there's still problems. So we're going to keep doing that. And we will, in that, you get to hear things because it's video and people are talking to their counselor. So we did learn a bunch. I don't know the answer to the question though. What happened to the 20%? What happened? So, please.
We have struggled in a variety of different studies. Improve the reach, improve the sort of portion of patients that sort of behavioral thresholds. I really like your get your PR every week motivation. It sounds like it's like self-determination theory, like this intrinsic motivation to self-improvement. I wonder, like, have you learned, like, how long does that last before people, by the 23rd week, are they still able to improve? Is that still a motivation? Do you use other sorts of simple motivation?
That's a great question. So I think, like all things in physical activity and human performance, the improvements are really brisk early and they plateau dramatically. So my sense is that people just are not willing to work hard enough, right? There's a limit to how hard humans, are going to work. Even I go to the gym and I'm not really willing to just push it that hard, right? So I think what's going to happen is that we get really brisk improvements, so people can look back and go, wow, I've come a long way. And then we're going to switch our messaging into loss aversion. I think that's the plan, is that you don't want to go back there, do you? Look how far you've come. And from a messaging perspective, I think there's some good history that's useful. People really fear losing and backsliding. And also the nice part is, once you've gained physical performance like that, your adherence doesn't need to be as high. So you do not need to do RT as many times to maintain that. It's much easier to maintain the gains from resistance training than aerobic in general. You can't just decide to only run once a week if you want to keep your mile splits low. But in resistance training, you really can reduce, and the data is pretty good that works. So but we're going to switch the message, because we're going to look at people, and I think you can tell when people are sort of, as long as they get a nice improvement. If you go up 6 chair stands or a whole standard deviation, that's great. you know, you're going to put off aging by a pretty large margin. You lose certain per year. We just need to build people up to the point they never become disabled. I think we can do that without pushing them to the edge. I don't know, more to come.